Welcome to Arch Ghost, the show focused on creating high caliber, adaptable, and prosthetically driven full arch surgeons. The surgical techniques described and depicted in this podcast are provided by Arch Ghost LLC solely for informational and educational purposes and are intended exclusively for properly trained, licensed, and clinically competent healthcare practitioners acting within the scope of their professional credentials. As a licensed healthcare practitioner, you alone assume full responsibility for all clinical decisions, actions, and outcomes as part of your patient care. Please see our full legal disclaimer at archghost.com/disclaimer. So today's episode is a continuation of last week's episode, and we are looking at another 10 full arch pearls, thoughts, and reflections. Again, this was a newsletter that I wrote a couple of years ago, and I just didn't have the space to really dive into more detail about these points in the newsletter. And so we're going to chat about them here and go into a little bit more depth. So with that, we'll jump right in. Number 11, tactile feedback is paramount to consistent full arch success. Learn to feel the bone. So one of the techniques that I teach, and I have an article on it if you want to look it up, but it's the low RPM osteotomy technique. And this is essentially, if I'm going to say it in a sentence or two, drilling slowly enough that you can get tactile feedback on the density of the bone. I often drill fairly slow when I'm making my osteotomies to really be able to assess the density of the bone. And my goal is that after I perform my starter drill, that I can actually tell my team, all right, at that point, I want a 4x13, a 4.3x11, a 4.3x11, a 4x13, or whatever the implant sizes are, because I know based on the feedback I get from the starter drill how dense or not dense the bone is, and at that point in time, I'm able to hone in which implant size I'm using. I always have an idea, obviously, of what size I'm going to use for the case, but it's at that point with the starter drill that I get the feedback, the tactile feedback on the bone, that I make that final decision on what size I'm going to use. And so being able to do that is what is going to give you the ability to consistently generate high torque. If you can't feel the bone, if you don't learn to feel the density, you will just consistently arbitrarily place whatever size implant you initially picked out, and it's just going to torque at whatever arbitrary torque it's going to generate. When you strategically select the implant based on the tactile feedback you get, that's when you're consistently going to generate 45, 50, 60 plus 70, Newton centimeters of torque on your implants. And you're going to do that the vast majority of your cases. So learning to drill slowly, learning to listen to that tactile feedback is paramount to full arch success. Number 12, closure says more about a surgeon than any other aspect of surgery. This is, I said this, so I feel obviously that it's true, but I feel that this is true. I think that taking the time to perform a pristine closure in this setting, I'll admit, when I was doing wisdom teeth and those types of things, I didn't necessarily take a ton of time to make a pristine closure. But in the setting of full arch surgery, I think that taking the time at the end of your case to ensure your closure is immaculate, really says a lot about the surgeon, because I feel that has a huge impact on the long-term health of the case, on the gingival architecture, on healing, on cleansability, on all those aspects. And, I do talk a lot about efficiency, but I never talk about being fast. And this is one point where I slow down and I really focus on creating the most optimal, pristine closure I can. And that's one of my pet peeves when I see other people's cases where things are just kind of tacked together willy-nilly. Or, I mean, I see multiple cases where people just put one stitch between the implants. The reality is, it'll heal, but I really don't feel it sets the patient up for long-term success with the way that the gingival architecture heals underneath the prosthetic. And I think that to me just shows a rushed case and a surgeon that doesn't care as much. And that's why I feel I can, I've seen a lot of different surgeries with a lot of different doctors, and I can tell what type of surgeon it is by how they do their closure. And I can tell how much they care about the case and how much they care about the patient. Number 13, not all wisdom teeth need to be removed. This may sound obvious to some of you that have been in the full arch game for a while, but I learned the hard way starting out. The biggest complications I've had with full arch surgery have been with taking out wisdom teeth as part of the full arch procedure. And as a young oral surgeon, I hadn't yet learned that maybe not all wisdom teeth, not all of them need to be removed. And so that is something that became quickly apparent to me. And, the way that I operate now with full arch surgery, to be honest, I rarely, take out any type of impacted wisdom tooth. If something's erupted, obviously it comes out. Soft tissue impacted will usually come out, but a partial bony or that's case to case. A lot of them will leave unless they have true exposure to the mouth or decay. Fully impacted teeth I don't touch. And the reality is that just a lot of our patients in this population are older and have other medical comorbidities that make healing more difficult. And it's just a complication that is easily avoided and not something that we need to go after. It doesn't necessarily impact the full arch case or the ability to do the arch. And so that's something that I've definitely changed over time. Not all wisdom teeth need to be removed. Number 14, our goal should be to treat almost all patients. Rarely is treating every patient the right answer in full arch surgery. I am, not embarrassed to say that I don't treat every patient. I treat almost every patient, but I don't treat every patient. There are patients that I don't feel are a good psychological fit. They just aren't understanding of the procedure, and I don't think they will tolerate it well, or they just don't have the demeanor. Some patients come in demanding things and, demanding promises or demanding this or that. And those aren't people that I'm going to treat. Some patients aren't medically optimized to the point that I'm comfortable treating them. That's a whole discussion. But if somebody's not in a medical state that I feel they can heal well, then they either are not a candidate or they need to have the assistance of their physician to, optimize those medical comorbidities before surgery. And the other side of that, some of the cases, they are just cases that from a complexity or difficulty standpoint, there are some cases that I don't take on. It's very rare. But out of 400 or 500 plus arches a year, there are a handful of cases, that I don't tackle, and that's okay, and you shouldn't feel that you need to get in over your head either. So I remind myself of this, and I always remind newer surgeons of this. Obviously, the goal is to treat as many patients as possible. And I do treat just about everybody, especially from a surgical difficulty standpoint. There's not too many cases I won't do. But in some of those other aspects, I remind myself that it is okay sometimes to say no, and that our goal should be to treat almost all patients, but rarely is treating every single patient the right answer, and oftentimes you'll end up in more trouble or with more complications by doing that. Number 15, it takes 100 arches to know what the heck you're doing and 1,000 to become an expert. That was a quote from my clinical director at ClearChoice when I started. And at that time, that seemed like such an astronomical number to me and something that I would never achieve, so far off in the distance. But I've looked back on that comment. I remember I texted him when I hit my 1,000th arch. I wasn't even at ClearChoice at the time, but I remember texting him and saying, I did it. I'm here. I'm an expert now. And I think looking back, now at just under 3,000, I think that there's a lot of truth. And I think that when you first start, until you've done 100 arches, you are still trying to figure out, what comes next and the steps and how to do it in under 4 hours. And, just getting your systems down, learning to manage basic complications. And to some of us, that maybe are in private practice, 100 arches seems like such a phenomenal number and you've mastered it all. But I promise you haven't. And that's not a bad thing. It's just, you've just figured out what the heck you're doing at 100 arches. Now, the next 900 is where you become good and you become an expert. And these things take time, I am a better surgeon now than I was at 2,000 arches, and I was better at 2,000 than I was at 1,000, and I was better at 1,000 than I was at 500. But I will say that the learning curve from 0 to 100 is like incredibly, shoots up rapidly. The learning curve from 100 to 1,000 levels off a little bit, but it still goes up significantly. Once you get to 1,000, that learning curve levels dramatically, and you still improve, but you're improving small areas of your surgery. And we never stop learning. I'm still getting better. But the point being that learning curve from that 0 to 1,000, there's so much learning that goes on. So keep that in mind, when you're going through these procedures. And I don't know at what point along that curve you're at. Maybe you're, above me and you've done 5,000 arches. Maybe you've done 5 arches. But understand that, hey, from a practical standpoint, it's going to take 100 just to get your bearings straight. So don't get discouraged during that time. Keep at it. And once you get around 100, you're going to get a little rhythm. You're going to get a little confidence. Don't get overconfident, but you're going to get a little confidence. And it's going to become more enjoyable. And then from 100 to 1,000, you can really focus on getting good. After 1,000, you can be confident that you're a strong, provider in that space. And you can start to just fine tune the little areas that you really need to focus on. All right. Number 16, adaptability is the single most important trait a full arch surgeon can have. Adaptability. There's so much that can be said about being able to adapt in full arch surgery. And I've talked about this many times and in many different forums and many different articles and in a few of the other podcasts. So it's nothing new. But the ability to have the mindset, it's not just the ability to do it, but the ability to have the mindset that you are ready and willing to adapt. That is going to take you a long way in this surgery. It's one reason that I don't like guides, and we've talked about this, but you can't adapt with a guide, and you've basically locked in the fact that you won't. You've shifted your mindset away from being able to adapt. If you want to be successful at full arch surgery and you want to immediately load, that's the key. If you're not going to immediately load, then fine, but you're not going to have many patients if you can't immediately load. If you want to immediately load, you have to be able to adapt. Being able to shift, to pivot intraoperatively, to adapt is just so critical to full arch success. And again, I challenge you, it's not just the act of doing it, but it's the mindset of how you treatment plan and of just you going into a case knowing, hey, at any minute this can change and I'm okay with that. That's going to take you a long ways. Number 17, mastering freehand surgery is paramount to immediate loading. So that's basically piggybacking on what we just said. If you want to immediately load your arches, you can't consistently use guides. You've got to be able to switch implant sizes, go wider, go longer, switch an implant site, add an implant. You've got to be able to generate adequate spread and torque and be able to adapt to any change intraoperatively that prevents you from doing that. And you have to be able to do that with freehand surgery. Freehand surgery is the best way to perform full arch surgery for immediate loading. If you don't want immediate load, then you can maybe, make the argument that guided surgery, is beneficial, but immediate loading is effectively the standard of care in full arch surgery right now. And, that is best done with freehand surgery. I challenge you to find an experienced full arch surgeon that is doing this at a significant level, 30, 40 arches a month, that is doing guided surgery. I don't think you can find one. And the answer is not, well, they have experience, so they don't use a guide. The answer is they are experienced. And as a result of having experience, they've realized that guided surgery is not the best way to do this surgery. Number 18, if you're not immediately loading the vast majority of your arches, you're falling behind the standard of care. The standard of care in full arch surgery is immediate loading. Gone are the days of delayed loading. There are cases, yes, that will happen where you have to delayed load somebody. But if your standard of care is that you're still delayed loading these cases, more power to you if you're able to get patients. If you're a referral-based practice and you're sending all these patients back without teeth to the restorative provider, I can't imagine that that's a good referral builder. And patients are savvy now. There's so much direct patient marketing. They know that they should have teeth, that it shouldn't take 6 months to get something fixed. So being able to learn the skills and the techniques to immediately load, I think if you want to do this surgery and be in this space, that's critical. Number 19, the prosthetic aspect of full arch surgery is just as important as the surgical aspect. One of my frustrations in the full arch world, as a surgeon, I appreciate that there's so much emphasis on the surgery, but I also am frustrated that there's not more emphasis on the prosthetic side, because as the surgeon, I want there to be more emphasis on the prosthetic side because I want to be able to work with more prosthetic providers that have a better understanding of what they need to do for a successful procedure. There's nothing more frustrating to me than the mentality that, well, the prosthetic side doesn't really matter. It's just hooking the teeth on. What really matters is the surgery side. When I hear things like that, or I work with restorative providers, fortunately, I haven't had to work with many, but occasionally there'll be somebody that kind of has the attitude that the responsibility for the success is really on the surgeon. That really irks me because they don't understand how much of both a negative impact and a positive impact on the procedure that they can have, and that they should have a positive impact. The prosthetic side is just so incredibly important. And you will see, if you track your cases, if you're a referral-based practice, when you work with somebody that knows what they're doing, you're going to have a higher success rate than when you work with somebody that doesn't. The occlusion, the cantilever, the lip support, the VDO, all those things that, especially prosthodontists and experienced restorative providers are great at understanding and managing, those all make a difference, not only in the success and the integration of the implants, but in the patient satisfaction. And a lot of the times, a lot of patient frustrations and how the prosthetic fits or feels, those are things that can be alleviated or don't occur as often with a very experienced restorative provider versus someone that doesn't pay attention to a lot of little details that really make up the important components of the prosthetic side. So, I challenge you as surgeons listening to this, if you think otherwise, you're going to become very good at performing remove and replace surgeries for your patients, because what your referrals do on the restorative side, it absolutely matters, and you should pay attention to that and take an effort in ensuring that's being done at a high level. Last point here, number 20. The mandibular external oblique ridge is a built-in, high-powered anatomical reduction guide. Check it out. So I have an article on this on archghost.com if you want to see it, some pictures and descriptions and things. But essentially, for your mandibular reduction, following the external oblique ridge around the jaw is going to provide you almost always a very close approximation of the reduction required for that patient. Now, as I always say, I'm not necessarily advocating that you don't measure it, but it's a good backup. It's a good secondary checkpoint. And it's just kind of a quick reference for you to make sure that you're in the ballpark with your reduction. But try it out. I use it every case as a checkpoint. Tracking that external oblique ridge around the jaw really provides a great approximation of the mandibular reduction. So that wraps up between last week and this week our 20 full arch pearls, thoughts, and reflections. This was part 2. And that's it. That's the pod. As always, remember, operate in the shadows, adapt relentlessly, and load them all.